So it's on the recording. You have a quiz on Monday. Over as far as we get in endocrine today. Okay? Cool? In class, yeah. And you guys are a little bit ahead of the other class. And you always ask fewer questions than the other class, so I don't know how far we'll get. We'll see. Okay, so we finished last time. We finished all 7 of these hormones. So you guys remind me of the things that we finished. All 7 of these hormones up here are headed where? Anterior pituitary. And all but one of those hormones is a peptide. Which one is not a peptide? Dopamine. What's the other name for dopamine? PIH, prolactin inhibiting hormone. Okay, so let me tell you guys something that's going to be important to you later for future reference. On your test, for instance, you have to write out the long name of the hormone before you can abbreviate it, and why. The why is because there's a lot of meaning in the long name of the hormone, and the other why is because if you say PIH or if you say PHI and you mean PIH, I have to count it wrong. But if, for instance, you spelled out the whole thing and said it's prolactin inhibiting hormone, I would still give it to you, right? Does that make sense? So it gives you a little bit more leeway for actually like making small errors if you actually know it. So you only have to write it out once, and then every other time you mention it on your test or whatever, you can abbreviate it, okay? So you just have to write it out once. Does that make sense to you guys? Okay, so the next place, of course, that we are headed is right here, which is the anterior pituitary, yes? Okay, ask as many questions as you want to today. Today is primarily about you getting to the point that you start understanding how the physiology of the endocrine system works. And if it's not clear to you, then just give me a sec and I'll try it a different way. I'll try to explain it a different way, okay? So let's start with these. So first off, remember that when we talked about the pituitary gland in phys, since the anterior and the posterior pituitary gland are entirely different in their derivation, like the posterior pituitary gland is really just an extension of the hypothalamus, and the anterior pituitary gland is really epithelial tissue that moves up from the roof of the mouth. That means that in phys, you can't just say pituitary. You always have to say anterior or posterior, right? So you have to be specific. Okay, now, there are 2 other names for the anterior and posterior pituitary gland. The anterior pituitary gland has another name. I don't ask you about it all the time, but I want you to know it. The anterior pituitary gland is glandular tissue. It's epithelial tissue. It used to be a part of the roof of your mouth before your skull developed, and then it moved up to sit next to its roommate in the sella turcica of the ethmoid bone, right? But it is glandular tissue, and it has a totally different relationship to the hypothalamus, okay? So for that reason, it has another name, and its other name is adeno, which means gland, hypophysis, which means pituitary, okay? The adeno hypothesis. Why am I making you learn that term? Because in your future pharmacology classes, if, for instance, they refer to the adeno hypophysial hormones, you'll be like, I don't know why the hell you had to say it that way, but at least you'll know what they're talking about, right? So the adeno hypothesis is the anterior pituitary. With that in mind, does it surprise you that the posterior pituitary's long name is the neurohypothesis, right? The nerve pituitary, right? Adeno hypothesis and neurohypothesis. Now, will I use those terms? Most of the time, no, but there will be at least one question that makes sure that you know what those terms mean. Most of the time, when I ask the question, I'll say anterior pituitary or posterior pituitary. Got it? Okay. So, now, we're going to do the adeno hypothesis first. It is connected to the hypothalamus by a vascular connection. So remind yourself of this because this is important, okay? If you're looking at hypothalamus to anterior pituitary, it's vessels that connect them, yeah? But if you're looking at hypothalamus to posterior pituitary, it's axons that connect them, yes? Okay, so this system right here is called a portal vessel, in which you have 2 capillary beds in series and there's a portal vessel between them. Nobody ever decided what to call that portal vessel, so it's either called the hypophyseal portal vessel or the hypothalamo-pituitary portal vessel, or sometimes they call it the HPA portal vessel, but it doesn't matter because there's only one portal vessel in the endocrine system. So if you see portal, this is the one it's talking about, okay? So don't let that throw you, okay? So this is the portal vessel. So what does this mean? Okay, so let's look at it. These 7 hormones, remember there were 7 that were secreted by the hypothalamus into this capillary bed. These 7 hormones don't go into global circulation before they go to their target. They go straight to their target. So what do you predict about the level of these hormones in the bloodstream compared to other hormones? Like, for instance, estrogen that comes from the ovaries and goes into the bloodstream. Yeah, it's much, much lower. You produce far less of these hormones than you do of other hormones because you don't need to produce as much because they're going straight from point A to point B. Yes? No, the ones that are going from the hypothalamus to the anterior pituitary. These guys right here, Shelby. These. Produced in really small quantities. Okay, does that make sense? Now, that means that clinically it's hard to test for them. If you go to a general practitioner, they probably won't test for your hypophyseal hormones or your hypophysiotropic hormones. But if you go to an endocrinologist, they can. Okay? All right, so we'll come back to that in just a second. So what we are going to do now is these hormones are going to cause something to happen here, right? So now we are going to be at the anterior pituitary, and the anterior pituitary was this orange box that we kept stimulating the last time. It is going to produce 6 different hormones. It actually produces 8, but we don't know what the new 2 that they just found do, so there's no reason to learn them, okay? So there are 6 different hormones. Who remembers the chemical category for all of them? They're all peptides, okay? Keep that in mind, okay? So let's start going through them. The anterior pituitary is often called the master gland, and we talked about this last time. It's called the master gland because it controls a bunch of other places in the body, but that was because we didn't know that the master had a master, right? So it controls a bunch of other places in the body. So let's look at the hormones that it produces. All right, so the only thing that I do not like about this diagram, because it's my favorite diagram in the chapter, is this part right here. So we're going to start right there. Okay, so the anterior pituitary produces 2 hormones that could be considered gonadotropins because they're headed where? To the gonads. All right. FSH is the first one. Okay. This implies that FSH and LH do the same thing, but they totally do not. So let me clarify that for you. FSH, I don't know how much meiosis and human sexual development you actually did. Generally in Utah, you didn't do any of it, honestly. There is hardly any education about human sexuality in public schools in Utah. So if I over-explain this, it's not because I'm doubting your intelligence. Okay, so do you guys know that during the process of meiosis, the developing gametes, meaning eggs and sperm, are supported by this big structure called a follicle? Do you know that? Okay, so it's called a follicle. And the follicle has the meiotic products that are developing in it. And so the follicle is going to support the developing spermatogonia, which will eventually become spermatozoa, oogonia, which will eventually become eggs, oocytes. Okay, so the follicle is supporting gametogenesis. Does gametogenesis mean anything to you? The development of gametes, which if you were male, you would call spermatogenesis, and if you were female, you would call oogenesis. Okay, so now back to what FSH does. Thank you. Look at this. Someone brought this back and stuffed it under my door today. Okay, so FSH, here's what FSH does. Targets the gonads, specific cells in the gonads, I don't care if you know the name of the cells, and causes spermatogenesis in the male and oogenesis in the female. Okay? That's why that figure is kind of wrong, right? Because it doesn't say anything about spermatogenesis and oogenesis, right? So FSH is going to target the gonads and cause spermatogenesis or oogenesis, right? Okay, now LH is going to do the other thing that the gonads do. It's going to target the gonads to do the other thing. LH is called luteinizing hormone, and luteinizing hormone will cause the ovaries to make estrogens and progesterone, and the testes to make androgens, including testosterone. Does that make sense? Okay, so collectively, do you see that those both together force really both of the 2 big functions of the gonads, the 2 big functions, which is basically hormone production and gamete production. Which one's responsible for gamete production? FSH. Which one's responsible for hormone production? LH. Got it? Okay. Okay. And of course, we're going to get back to those. We'll talk more about what those do when we get to the gonads, right? Okay, so that's FSH and LH. Okay. Okay, FSH and LH, they are both considered gonadotropins, and we said that. Does that make sense to you guys, that they're both considered gonadotropins? Okay. The next one is growth hormone, and growth hormone is here. Growth hormone's other name is somatotropin. Does that mean anything to you? Somatotropin? What does somato imply to you? Like body, right? Right? So the reason it's sometimes called somatotropin is because it targets almost everywhere in the body. And it is growth hormone. So does it surprise you that its primary, like simplified function in almost all cells, is that it causes protein synthesis and cell division? Isn't that growth? Yeah? Protein synthesis and cell division? Okay, got it? Okay, now, this textbook right here says that it does something special with the liver. I don't care if you know that. Basically, what it does is causes the liver to make some paracrine agents that also support growth. But really, it goes almost everywhere in the body. Is that okay? So that's growth hormone. Now, you need growth hormone when you're growing, of course. You also need it as an adult in order to do repair and regeneration of tissues. You need more when you're growing, right? And you need less as an adult, but you still need it, okay? All right. So that's growth hormone. Next one is TSH, thyroid stimulating hormone. Where's it headed? Thyroid. Its other name is thyrotropin. Yeah? And it's going to go to the thyroid. We will look at what it does in a little bit more detail later, but a little blurb about what it does is that it's going to cause the thyroid to secrete T3 and T4, those thyroid hormones that we talked about before. It's going to cause the thyroid to secrete those. Okay? All right. Next one. Prolactin. Prolactin. Its name doesn't tell you, but it kind of implies one of its major targets. It's prolactation. So one of its major targets is where? Yeah, the mammary glands, the breasts. It will cause lactation to occur. So of course, that would mean that you hardly ever use it, right? Okay. But we actually figured out recently, not we, but people, that it's not just produced in women, and it's not just produced during pregnancy and lactation. So apparently it does far more than we thought it did. One of the things that apparently it does in both sexes is it is also produced during orgasm as a reward for sexual acts. It's dumped into your bloodstream during orgasm in both sexes, okay? So it took us forever to figure out even the beginning of why the heck guys would have prolactin. I mean, obviously you have nipples, but you don't use them for that. The only reason you have nipples is because the nipples developed before sex differentiation happened. That's the only reason that they're there. So prolactation targets the breasts, but it actually goes back into the bloodstream, back to the brain. It's part of what makes an orgasm pleasurable. An orgasm is just like this big freaking chemical cocktail that is CNS, yes, in the brain, like dopamine and endorphins in the brain. But it's also PNS, causes relaxation, right? And it's also endocrine. It causes hormone release as well. So collectively, the impact is really, really powerful. Otherwise, there wouldn't be 7.5 billion people on the planet, right? Okay. It will cause you to seek it out again. Obviously, dopamine's released up here, right? Okay. So apparently, they have figured out that prolactin is one of those hormones that's released in both sexes during orgasm. So that's probably why guys have this whole regulatory system, but we don't know as much about it as we want to yet. Okay. The next one is ACTH, and ACTH is adrenocorticotropic hormone. Where's it headed? Adrenal cortex, exactly. Its other name, not as commonly used, I don't think, is just adrenocorticotropin, right? But it's not hard to figure out what that one's talking about. Everybody okay with that? So adrenocorticotropic hormone is going to the adrenal cortex, and we will figure out more about its function later, but its major function is that it causes the adrenal cortex to release cortisol. Cortisol is a fascinating hormone. It's the most complicated one that I have ever encountered. So I'll do my best when we get to the adrenal cortex to explain it clearly to you. Okay, so the chemical class of hormone All 6 of these hormones that we just talked about, all of them are peptides, yes? Okay. And for each of the hormones, you are going to have to start to put together a chain, because remember, these hormones are not there in isolation, right? So why do you release FSH and LH? Well, you release it because the hypothalamus released GnRH, okay? So you're not ready to make your hormone chains yet, but I'm telling you that it's coming, okay? So, by the way, interestingly, what puberty is when you start to produce this for the first time. Because what are your gonads doing before puberty? Just hanging out, just doing nothing, right? Just sitting there, not causing any zits, not causing any problems at all. And then GnRH kicks on in the hypothalamus, which is primarily genetically controlled. If you are from one of those families in which the girls hit puberty at 8, probably going to hit puberty at 8 or 9, okay? So GnRH is primarily, when it starts being secreted, is primarily genetically controlled. Go ahead.
Are the anterior pituitary hormones produced and stored until?
Yes, they are. They're produced and stored because they're released by exocytosis. That's a good question. There's actually an exception to that, but I'm going to say yes globally and think about the asterisk in my head because you don't care anyway. Okay. Everybody okay? Anterior pituitary hormones? Okay. So now we're going to do our first disorders. So I want you to listen to this part and think and tell me if you don't understand. Do you see why, if I had a disorder in any of these hormones, it would actually look like an anterior pituitary disorder? Do you see that? Okay. So, interestingly, we don't usually diagnose disorders up here because the level of hormone is really low and you'd have to go to an endocrinologist. And the other thing is we don't usually treat them if they are up here because in order to do so, you would have to deal with the blood-brain barrier. Does that make sense? Because isn't that part of the nervous tissue in the hypothalamus? Yeah? Okay, so I am definitely not saying that there are no hypothalamic disorders. There totally are. But even if they occur, a lot of times they don't even treat them at the hypothalamus level. They just treat them one level down. They just treat them at the anterior pituitary level. That makes sense? Okay, so that's just a tidbit about why I didn't teach you any disorders that go with those, because most of them just look like disorders of another organ. Okay, so, but we do have some disorders that occur here. So, same idea. Do you see that if you had a TSH disorder, it would look like a thyroid disorder? Yeah. If you had an ACTH disorder, it would look like a cortisol disorder. Yeah. If you had a prolactin disorder, you probably wouldn't even care except for the time that you were trying to lactate. Yeah. And by the time that was over, you would have already been bottle feeding, the kid would have been weaned, and then you would be fine, right? So even though this totally occurs, we don't usually treat it. We're like, well, apparently you're not going to lactate. Here's some really good quality formula, right? Don't feel like a failure because all moms have some issues, man. Okay, and then, but what about here? If you had an FSH or LH disorder, it would manifest as some kind of reproductive disorder, yes? Okay, but this one is the end of the chain and can cause problems that would, of course, show up, yes? Growth hormone being the end of the chain. So the primary anterior pituitary disorders that I'm going to teach you are related to growth hormone, okay? And also they make for pictures that you can actually see the difference in people because it's related to growth. Okay, so before I tell you, let's predict. If you had a hyposecretion, too little of growth hormone during your growing years, what can you predict? You'd be tiny, yeah. And if you had too much of growth hormone during your growing years, you'd be really tall, right? Okay, so you got it right, because there are 2 different types of growth hormone disorders that will be really obvious to you, and one is called pituitary dwarfism. Pituitary dwarfism is not this. This is a type of dwarfism that is genetic, not endocrine. Do you see that with this baby? The head and the torso are relatively normal stature, but the limbs are shortened. This is called achondroplasia, and achondroplasia is genetic, okay? And so this is not an endocrine disorder. I want you to look at the proportions on this baby and compare this type of dwarfism to this type of dwarfism. Do you see that the proportions of this person are so completely average that you might not even know he was a dwarf unless you had someone for scale? Does that make sense? Because it affects basically the growth of almost all of your tissues pretty much the same. Okay, so this is called pituitary dwarfism. And so you're going to have somebody who's really short stature, but the proportions are pretty much the same. So it's not achondroplasia. So I'll show you another picture of someone with pituitary dwarfism. This is grandpa, and these are his grandchildren. right? And he had pituitary dwarfism, right? No, it's not genetic. It's endocrine. Yeah, it's endocrine. So you wouldn't have inherited it. Achondroplasia is autosomal dominant genetic, and so it's a big world. People, what is it?
Big people,
Little people, big world. Their family has achondroplasia and it's inherited, and you can see it passed down. Or if anybody lives in the Avenues, Hatch Family Chocolates is owned by a family that has achondroplasia running through their family. So they've got a family with achondroplastic dwarfism. Okay, so this is pituitary dwarfism. Why do you see achondroplasia but not pituitary dwarfism most of the time? It's because achondroplasia is genetic and you really can't treat it. What happens with achondroplasia is it impacts the epiphyseal plates of your long bones but not your other bones. And you're born with it, and there's really no treatment for it. But with pituitary dwarfism, it's a hyposecretion of growth hormone during childhood, and we know how to make growth hormone in the lab. So you can treat someone after they've been diagnosed with pituitary dwarfism. Go ahead, Casey.
So you're saying that pituitary dwarfism isn't genetic.
Yes, it's not.
What would cause the endocrine system to do that?
Usually it's some metabolic disorder in which like something's wrong with your pathway and you can't actually produce something, or you get something wrong with your pituitary gland and you can't produce it. Sometimes it can be related to a benign tumor, but you don't pass it down, right? It's not something that is a mutation, for instance, in a genetic code. It's something that's basically an accident in the metabolic pathway. Is what's happening. Go ahead.
So is an oversimplification to state that things are either or the combination of hereditary and environmental factors,
You could have a hereditary predisposition to it that was activated by some environmental exposure. Yes.
That's more inheriting than passing down.
You are generally not going to pass it down. You may have inherited a predisposition and then got an environmental, kind of like cancer. Do you inherit lung cancer? No, but if your family had it and then you got exposed to something, you might be more likely to have it because it was in your family. Does that make sense? Yeah, right. Go ahead.
I was going to say similar.
Yeah, like that. Okay. So even though there may be a congenital aspect, it's not as if this man would, for instance, pass it down to his progeny.
It's not like recessive.
Right. It's not like that.
Not gene related. It's just
Right. I mean, it could be gene related, but it's not exclusively gene related. Achondroplasia is.
So if you have siblings that are all dwarfs, would it be safe to assume that it's not pituitary?
It would be safe to assume that it's probably not pituitary. Yes. There would be an increased predisposition in his family because he probably had something, but you don't inherit it. But with achondroplasia, since it's autosomal dominant, it's just a simple genetic mutation. It gets passed down directly. Does that make sense? Okay, so those are good questions. All right, you ready? So why do you not run into, in the Western world, people with pituitary dwarfism very often? Well, actually, decades ago, we figured out that you could actually get growth hormone from cadavers. Where we used to get growth hormone, they would just suck it out of the pituitary gland of a cadaver. But that meant that it was not readily available and pretty cost prohibitive. Yes, not readily available. In addition, after prion diseases became an issue, you guys know prion diseases like Creutzfeldt-Jakob disease and mad cow and all that kind of stuff. We stopped trying to do brain-to-brain human stuff if we could avoid it. But luckily, through genetic engineering, we figured out the protein sequence for growth hormone, so we can make it in the lab. So now if someone is diagnosed and they're not hitting their growth milestones, then you can test what their level of growth hormone is and figure out whether they have pituitary dwarfism. And you'll usually find out when they're relatively young. And then what you do is you just start shooting them up with growth hormone, right? I mean, parents have to get permission, but you can start shooting them up with growth hormone. Okay, question for you, logic question. It's a biochemistry question and a physiology question. Why do you have to shoot it up instead of ingest it? Growth hormone, go ahead.
Because it goes straight into the bloodstream.
Straight into the bloodstream. What would happen if you ingested growth hormone?
So it's similar to insulin.
Similar to insulin, so it's peptide, right? What happens to peptide, right? It denatures in your stomach long before it gets absorbed. So if you're dealing with a peptide hormone, it has to be replaced. Not like thyroid hormone. Thyroid hormone is lipid soluble. You can just take it orally. But this one you would have to inject, right? So inject instead of ingest. Okay, so you could shoot them up. And until they hit puberty and the sex hormone increase would cause their epiphyseal plates to close, then they would continue to grow. So about 10, maybe even 15 years ago, when I first started teaching, one of my students had been diagnosed with pituitary dwarfism. I met her when she was in her 20s. She was 4'11", right? So she was tiny, but she was not like 3'2". She was not dwarfed, right? Or diagnosed. I mean, she was, but she had been treated until her epiphyseal plate closed, and then she can't get any taller. Now, of course, since we know how to make growth hormone, people want to use it for other purposes, right? And so you've probably heard about athletes shooting themselves up with growth hormone because it causes protein synthesis and increases muscle mass. If you're a competitive athlete and you have too much growth hormone, they won't let you compete. They don't care where you got it because you ain't going to compete, okay? And then there was like a really, there are parents sometimes who decide to shoot up their children because they want them to be taller, even though they're diagnosed with pituitary dwarfism. There was a 2020, and it was probably 5 years ago that I saw it, and it was about a family. And this family, I think, if I remember correctly, they had 4 kids. They were a super jockey family, like a really, really throw things at other things into baskets. Family. You know, get the ball down there and then get it back down there and think, what? Okay, you just took it there. Just leave it. Okay. So anyway, this family had 4 kids, and the eldest son, all of the 3 other kids were big kids, like big jockey kids. But the eldest son was just a small kid. He was not a dwarf. He was just a small kid. And so they chose to start treating him with growth hormone, I think about the age of 8. And they started shooting him up with growth hormone because his other siblings were already taller than him. So they just chose that, and insurance didn't pay for it, but they were loaded. So they just did it anyway. And my thought at that time was like, I really hope you saved for therapy. Because like, you just let him know that he was like abnormal in an unacceptable way to you. So families have been doing that. What?
Especially the women.
I know. So hard. So anyway, families have totally done that, and growth hormone is pretty readily available now, and it's available enough to be abused. Okay, so that's pituitary dwarfism. And then the other problem is if you have too much growth hormone before your epiphyseal plates close, what's it going to cause? Gigantism. And you guys know this guy, right? Everybody move! Yeah, he was a pituitary giant. And he had some other problems as well, but he had pituitary gigantism. He, if I remember correctly, had a benign pituitary tumor that caused hypersecretion of growth hormone. So why wouldn't you go take it out if it was benign? Because if you took it out, you have to replace all of these for the rest of your life. And some of them are related to survival, right? So if it's benign and it's just causing you to get bigger, sometimes they choose not to intervene. Okay, go ahead.
So is the tumor directly correlated to the disorder?
Yes, and usually you'd have other things that were screwed up as well. Usually if you've got,
Tumor, you have that problem.
if you have not always, but yes, quite often. If you have a benign pituitary tumor, one of the symptoms is very likely that you'll have a hypersecretion of growth hormone. Now, if it happened during adulthood, you wouldn't get this tall, right? Because your epiphyseal plates would have already closed. Okay, so Andre the Giant was a pituitary giant. These two are identical twins, and he has a benign pituitary tumor. So you can see the dramatic difference between the two of them. And it's not just height, but also look at the bone growth in their face, right? Do you see how much sort of like a really sharp jawline and brow ridge? And these are their feet of the same 2 young men, okay? So that's pituitary gigantism. It's caused by hypersecretion of growth hormone during childhood. But what happens after the epiphyseal plates seal. What happens after the epiphyseal plates seal with gigantism is that you can't get any taller, but there's nothing to say that you can't have appositional growth in width of your bone. So what will happen is you will see the things like this, like his jaw starting to get way, way more dramatic than his brother's, and his brow and his zygomatic arch. You can also see the same thing in Andre the Giant. He wasn't just tall. His fingers were also about like 2/3 the size of my wrist. He was just really, really, really big. And so is there any risk to pituitary gigantism? Yeah, it's really hard on your body when you get well above human height or weight ranges. And he was over 400 pounds. And it's really hard on your cardiovascular system. And he died in his 40s. He also drank like a freaking fish, like entire like kegs, like at a time. And then nobody could move him when he passed out. So that probably didn't help his long-term longevity. So when you continue to produce it after your epiphyseal plates have closed, it's called acromegaly. When you have a hypersecretion of growth hormone during adulthood, can you see how it changes the structure, the bone structure in his face? Can you see that? That's called acromegaly. Now, of course, it's pretty dramatic in him, but it's also really, really dramatic in women, because part of the reason that your face looks like a female face and not a male face is because testosterone actually causes the jaw, the orbital ridge, and the zygomatic arch to increase in size. It's part of the reason that a male face looks male and a female face looks female. So look at this woman, 9, 16, 33, 52. Right? You can see the dramatic change in the facial structure that it made. Go ahead, Shelby.
So I have a misunderstanding of it. So is acromegaly the later stage of the gigantism? Or is it completely?
Well, you don't have to have gigantism to have acromegaly. So for instance, if I got a tumor in adulthood, I would just have acromegaly, right? If I had a tumor that started in childhood and I never treated it and let it stay there, after my epiphyseal plates would close, I would get acromegaly. What were you going to say?
I don't know if I should ask this like after
No, it's fine.
explaining it. So my husband's aunt actually has acromegaly.
Oh, interesting. Did she get it in adulthood?
Yeah, so it's like a big, really kind of, it's very, we don't really know exactly what happened.
Okay.
She started changing when she was in her 20s.
Okay.
So now she's like almost deaf, almost blind, and she's can't really walk well.
That part of that happens because of the growth of the bone in the inner ear. It can cause like compressions on the nerves.
So she lives in Peru right now, and like it's really sad because she's also like she's not the same like mentally.
Mm-hmm.
So they ask me all the time like, what can we do about this? Like,
Well,
they don't know like how to treat it, and like doctors down there like are like, you need to go to the United States, like because they'll like help you over there.
yeah, that's probably would have been what she could do after she's already had this like inner ear damage and like probably compression of her optic nerve. She's going to have trouble avoiding the other things, right? But it's not untreatable. But let's talk about that just from a clinical perspective. What do you think is easier to treat, hyposecretion disorders or hypersecretion disorders? Hypo are way easier to treat. Hyper are more difficult to treat. It's usually either an antagonist, if we know a medicine that's an antagonist, and we don't always, and or it's surgical intervention. So for instance, when it was starting to affect her eyesight and her hearing, they may say, okay, we need to actually go remove your pituitary gland, which is actually less invasive than you imagine. It goes straight up your nose. It's not even like an open brain surgery. It goes straight up your nose to your pituitary gland. Does that make sense to you? Okay, so this is acromegaly, and you do not have to have both, although quite often, if you had it as a child and you didn't treat it, you will end up with both, right? And you can see what happened in those situations. Okay, so these are your 3 disorders. How do you handle disorders on your table? You need to know whether it's a hypo or hypersecretion of what hormone and when, right? That good? So which of these is a hypersecretion of growth hormone during childhood? Yeah, pituitary gigantism, exactly, right? And a hypersecretion of growth hormone during adulthood would be acromegaly. Is that good? Okay. All right, go ahead.
So have you ever heard the term like someone's big boned or
Uh-huh.
like has thicker? So would that acromegaly would be like more severe.
Yeah, acromegaly is like a disorder that causes someone to have really dense bones. But a lot of times when they say you're big bone, they mean you're chubby. And they ain't just saying that you're chubby. But in addition, there are also genetic predispositions to having denser bones. Do you guys know this? Like certain population groups have more dense bone mass than other population groups. One of the reasons that people of African descent are less likely to get osteoporosis is because their bone mass is thicker than people of Caucasian or Asian descent. So you can have dense bones, but that's not usually what this is about. Okay, everybody good? All right, so we're now, go ahead.
So you were just saying hyper, hypo, and when?
For that one,
For
there's
that one? So
there's
it's
going to
not
be,
just an overall thing of figuring out.
because there's also going to be hypo and hyper responsiveness, but I haven't taught you any of those yet.
Okay.
Mhm.
So, can like a tumor that affects the anterior pituitary, could it also affect any of the other hormones?
Yes, quite often it does. Quite often you will have a whole bunch of jacked up anterior pituitary hormones. But they have to figure out how serious it is, because if I go in and take it out, and they would if it was malignant, right? Because it was going to kill you anyway. But if it's benign, you have to be really careful about making that decision, because how well do artificial feedback loops work compared to yours, compared to your homeostatic feedback loops? No, they don't work very well. It's very difficult. And we'll talk about that when we get to thyroid, when we get to that in just a minute. Okay, so now let's do the next part, which is the posterior pituitary. You ready? Okay. So the posterior pituitary is an entirely different control mechanism than the anterior pituitary. Anterior pituitary was those 7 hormones are secreted from the hypothalamus, and they go through that vessel, portal vessel, to the anterior pituitary to cause or inhibit the secretion of something. The posterior pituitary, look at the connection. Posterior pituitary is really just a neural extension of the hypothalamus. Why do you release stuff into the posterior pituitary? It was made up here and released because of an action potential. Okay, that makes sense? Okay, so let's talk about each of them. Okay, so the posterior pituitary is also called the Adeno Hypothesis. And the chemicals that are released there were made up in the hypothalamus, and they're released via exocytosis. They're released just like they were a neurotransmitter. They're just not released at a synapse. They're released at a capillary, so they end up being a hormone, right? Okay, now, the posterior pituitary secretes 2 hormones, and these 2 hormones are interesting. Okay, so the first one, let's talk about what we've known for a long time about its functionality. This one is called ADH, or vasopressin. So let me tell you the long names of it, and then we'll talk about the functionality, and you guys can start to predict some stuff. ADH is called anti-diuretic hormone. It implies but doesn't tell you the target. Kidneys, yes. And what's it going to do with the kidneys? Make you pee more or pee less? Less, right. It's going to make you retain water. What would that do to your blood pressure, by the way? Increase it. Okay. It's got another target that is implied by its other common name. Its other common name is vasopressin. Vessels. Okay. What could you do with the vessels that was consistent with what you just did at the kidney? Constrict. Yes. Systemic vasoconstriction. Does that make sense? Both of which would increase your blood pressure. Okay. So why do you release this one? It is released because these hypothalamus cells will detect either not enough water in the blood plasma, like it's too hypertonic or something. Does that make sense? Or low blood pressure. Either one can cause them to say, okay, it's time to release that. That make sense? Okay. All right. There is, however, over the last 10 or 15 years, another reason that we release vasopressin, which is really interesting. It's not related to the osmolarity, and it's not particularly related to blood pressure regulation. It's related to orgasm. And vasopressin is released in both sexes upon orgasm, and it causes pair bonding, but it's not the kind of pair bonding that you usually think of. And it's released in all kinds of mammals. People get all pissed off about it when you talk about it in humans. So we'll do my best, okay? So it is released in both sexes during orgasm, and it causes a kind of pair bonding. So you know a little bit about the oxytocin pair bonding, right? Which is sort of the monogamy, you're my partner pair bonding. Okay, we'll talk about oxytocin in just a second. This one is a different kind of pair bonding, and it's released in a higher proportion in one sex than the other. It is the kind of pair bonding that increases territoriality, increases male-male aggression, and increases possessiveness over the mammal you just had sex with. So, which sex do you think tends to secrete more of this? Males secrete more of this, and it seems like it's a criticism, but it's actually an evolutionarily stable strategy, because I want you to think about males and females. If we want to not talk about humans, that's totally cool with me. You can pretend we're all monogamous if you want to. Okay, but let's just talk about a non-human primate, for instance. Another non-human primate. And almost all mammals, by the way, have this system of vasopressin and oxytocin. Okay, which sex, after mating, is most at risk, most vulnerable? The females are most vulnerable. The males are not particularly vulnerable, not physically vulnerable, but it might cost them quite a bit of their resources, for instance. So, if you impregnate another mammal, and you are going to use your resources to raise that other mammal, whose mammal do you want to raise? Yours. So it increases territoriality, it increases male-male aggression, and it increases this sort of possessiveness. So instead of that's my boo, which is oxytocin, it's that's my bitch. That's what it is, right? Okay. Interestingly, they have done some sociology experiments in which you can get men together playing board games. And if you expose them to a combination of high levels of testosterone and high levels of vasopressin, they will come to blows over monopoly, right? And it's kind of interesting. Now, do women actually release vasopressin? They do. And there are probably women who release more than men. But if you're looking at averages, men tend to release more vasopressin than oxytocin. Yes? Okay. Then we'll talk about oxytocin. Go ahead.
So what are the other names of these hormones?
Mm-hmm.
So say this one's vasopressin. So ADH is vasopressin.
Yes, it is vasopressin.
ADH.
Yes. And usually, by the way, if you're talking to a urologist, they'll talk about it as ADH. And if you're talking to a cardiovascular specialist, they'll talk about it as vasopressin. And if you're talking to a reproductive endocrinologist, they'll talk about it as vasopressin. It just depends on their convention. Okay, you all right with that? All right. So that's vasopressin. There is a disorder associated with that one. It's not at all related to its sexuality function. But it's interesting. And this is actually, I don't know, they haven't even tested it for sexuality because they only figured this out recently. But let's just assume we're talking about its blood pressure and osmolarity regulation function. So the posterior pituitary, it also could be a hypothalamus disorder because if something happened in the hypothalamus, you couldn't make it. But generally, this disorder is going to be called diabetes insipidus, but you have to dump your former meaning of the word diabetes. The word diabetes just means you pee a lot. And that's true with both forms of diabetes. Okay? This form of diabetes doesn't have anything to do with sugar or insulin. You just pee a lot, but your pee is insipid. Do you know what the word insipid means? Bland or stupid. So your pee is not tasty and sweet. Okay? Because somebody used to taste it. Okay, diabetes insipidus, you pee a lot and your pee is bland. Does it make sense to you that this is generally because of a hyposecretion of ADH? So wouldn't you pee a lot if you didn't make enough ADH? Yeah, you would, right? You would pee a lot and your blood pressure would tend to be a little lower than you needed it to be, right? This one's treatable. It's a peptide though, so you have to inject it. It's not super common. It doesn't have anything to do with sugar at all. You're just going to pee like a racehorse. Now, how did they tell it, historically speaking, from the form of diabetes that has to do with sugar and insulin, is if you pee a lot and your pee is sweet, it's diabetes mellitus. Mel means sweet, okay? So somebody historically tasted it. It wasn't the person with a college degree, so you're in the right place, right? They were not the pee taster. They were not. Okay? So we'll talk about diabetes mellitus when we get to insulin. They don't taste it anymore, so don't worry. It's not like the CNAs have to taste it, guys. It's not like that. You've got got all kinds of tests. Okay, so that is, what is that? Hypo or hypersecretion? Hyposecretion, usually. It can also be a responsiveness, but it's usually hyposecretion of what hormone? ADH from where? Posterior pituitary. Got it. Okay. Now, let's talk about oxytocin. Oxytocin is released, again, just like it was a neurotransmitter, but it's not. It is released primarily due to sensory input. Okay, so we've known about it for a super long time because of the whole mother-child thing. So let's talk about that and get that out of the way, and then I'll tell you what the other parts of it. So oxytocin is also the hormone that causes uterine contraction during childbirth. Yes? Okay. And this uterine contraction during childbirth also causes this bonding between the mother and the baby. It's this sort of chemical bonding. Okay. And it's a really, really evolutionarily stable strategy too, because anybody in here who's a mom, you are lying if you look back and think that your baby did anything entertaining before about 6 months.
2 years.
Right. But you kept them alive, didn't you? You totally did. That was oxytocin. That's what that was, right? So oxytocin is released in large quantities during vaginal delivery. It's also released during nursing and during skin-to-skin contact, and we have known that for a really, really long time. It's very stable, right? It helps us keep our babies alive. Go ahead.
So is that part of postpartum depression?
They do think that oxytocin levels are usually a little lower in women who experience postpartum depressions, but they don't usually test it. It's not like in clinical trials very many places. Go ahead.
So my friend, she was pregnant and she was in labor, and so does that mean she was releasing the oxytocin?
Generally, yeah.
So then she got to a certain point, and then she started like going backwards.
Backwards?
Like
Like the baby just come back up?
she was dilating, and then she started like closing,
Oh,
and then she had to have a C-section.
yeah, she stopped releasing oxytocin. Sometimes the positive feedback loop isn't good enough to get the baby out.
So
Go ahead.
So in like scheduled C-sections, would you just not release it?
You do release it. You don't release it in large quantities. I had a scheduled C-section. I couldn't go through vaginal delivery because I had a heart problem. So I never went into labor, right? But we know also that you also release oxytocin during skin-to-skin contact between the mother and the baby, and also during nursing. So of course I was a biz nerd, and I was like, well, I need to make sure I take care of this. So like everybody was naked, all rubbed up against each other all the damn time. So and then of course, I mean, this also means that, and it's uncomfortable for everybody to talk about. This also means that chemically, is the dad going to chemically bond with the baby as quickly as possible? No. Can you do anything about that? Yeah, you totally can. You can do skin-to-skin contact. You totally can. Yeah, skin-to-skin contact. Now, it doesn't just work during childbirth and parturition. It also, Marissa, it also works if you have 20 seconds of skin-to-skin contact with someone you are fond of, you will release oxytocin. If you are not fond of that person and they are touching you, you're going to release an entirely different hormone, right? And she's like, this is weird. You're releasing cortisol. So 20 seconds of skin-to-skin contact will also cause oxytocin release. Oxytocin feels good. It lowers your blood pressure. It calms you down a little bit. It kind of feels like, that's what it kind of feels like. All right. Now, you also release oxytocin during orgasm. So oxytocin is released in different proportions in males and females. Typically speaking, this is looking at averages. Oxytocin causes pair bonding. In organisms that are truly monogamous, there are large levels of oxytocin released between the organisms. There's only like a couple of monogamous mammals. We are not monogamous mammals. You can behave monogamously, but that's your prefrontal cortex, right? Deciding to behave monogamously. Historically speaking, we are at best serial monogamists, right? We are serial monogamous. Why? Why in women is it an evolutionary, or even in female non-human primates, if this offends you? Everyone always argues with me about this. I'm like, it's just in the journals. I don't know what you're trying to pretend to yourself that you're monogamous, but I saw how you reacted. So in female non-human primates, why is it an evolutionary stable strategy to pair bond with people that you have sex with? Yeah, because sex is really risky for the female. It is really resource intensive. It's really physically vulnerable. It's really risky for both you and the baby, and it's really, really hard to do it alone, the resources that are involved. And I'm not just talking about money. I'm talking about even primates. Like, where the hell do you get all the leaves that you need, right? How do you keep somebody from eating you right after you had the baby, right? So that pair bonding tends to happen with women when they have sex. It is less likely for men to release as much oxytocin as vasopressin, right? And that's an evolutionary stable strategy as well. They are also not as much at risk, right? They don't need, for instance, that particular pair bonding. Now, everybody hates it when you talk about that. However, you can also do the measurements and you can figure out that it happens. So women tend to release far more oxytocin. So ladies, you have to be careful who you have sex with because you might not like them at all. You might just oxytocin them. And then if you take a breath, it'll go away and you'll be like, why the hell are you eating my breakfast? Right? What the hell is going on? So oxytocin, which is what I wear around my neck that my husband got me, is the pair bonding, and they call it the love molecule or the cuddle molecule, but I didn't tell the other class because I forgot. But let me tell you something else that they found out about oxytocin that's not even related to sex. Super, super interesting. So they not only figured out that oxytocin, it gets this really good reputation, right? Because we're all like, oh, pair bonding, you're my boo, everything's great, we'll be together forever, like a Disney movie. But oxytocin apparently also causes more tribal behavior. So if, for instance, oxytocin makes me identify you as one of my people, it means that if you were at risk, I'm more likely to put myself at risk to basically do something for you. But if I identify you as an out-group, it actually increases aggression between out-groups. Do we not have some tribalism issues that we are dealing with at this particular point in history, right? Probably the reason I get called a libtard on like Facebook 2 times a week. So it increases tribalism and it increases in-group solidity, but it increases out-group aggression. So oxytocin is kind of an interesting one. So it's not quite as cuddly as everybody thinks of it. Okay, so that's oxytocin. So you should be able to fill in the columns. We don't have any disorders of oxytocin, but we probably do have disorders of oxytocin, honestly. I would be interested to find out if they ever did a long-term clinical trial about postpartum depression or women not bonding with their children, whether it's related to oxytocin. One of the things that people tried to do when they figured out that oxytocin caused pair bonding is they tried to figure out, what if I can make him snort it, right? Would it cause artificial pair bonding? Yeah, you can squirt it up their nose. Go ahead.
I was just gonna say, my sister had really severe postpartum,
Mm-hmm.
and she was a pretty interesting blog writer for a while. And she wrote about how her baby was a stranger. She didn't want anything to do with it. There was times she was suicidal, all these things. It was just interesting that not whatsoever. She didn't want any.
Yeah, I would love to know the biochemistry that's going on with postpartum depression. The problem is that where do you find your research group and how do you know that your research group is going to be available, right? And how do you get someone with postpartum depression? And there's so much shame associated with postpartum depression. How do you get someone with postpartum depression to volunteer for this clinical trial to assess their hormone and neurotransmitter levels? It would be fascinating to learn, but I don't know how to set up that kind of clinical trial, right? Go ahead.
So those orphans in Romania, when they aren't given the care that they need
Yeah.
until they aren't developing properly,
Yeah.
is that because
They don't know.
don't have the bonding?
They do not know. That's another one that would be great, but to use in clinical trials, but you certainly wouldn't want to be in the control group, would you? No? No human clinical trials with children in which you force them into a control group that's not going to be touched. They have done that with monkeys, though. And it ain't a pretty story. Go ahead.
So what would be the target
Of oxytocin, it targets a bunch of different places. It causes muscle relaxation, but it targets back to the brain as well. Yeah. Okay. But if you're talking about childbirth, oxytocin also targets the uterus to cause parturition, and it targets the breast because although prolactin causes lactation, oxytocin causes milk letdown. Does that make sense? Okay, go ahead.
I don't want to sound dumb.
You're not going to sound dumb. Nobody knows this stuff.
Yeah, I heard you talking about it.
Can these be things just by thinking about?
Oh, yeah, so that's good. So, yeah, that's just recently been assessed. One of the things that they just recently figured out is, first of all, that oxytocin is super duper good for you. When I talk to you guys about stress, one of the things that can actually counteract a lot of the impacts of stress on your body, the physical impacts, is releasing oxytocin. So you release oxytocin if you are with someone that you care about. You can release it just from being in the same room with them. You don't even have to touch them. You also release a little oxytocin if you talked on the phone to someone that you like, but not as much as if they're in front of you and not as much as if you touch them. You also release oxytocin when you make eye contact with your dog, and so does your dog. The jury is still out on cats. I don't think they care about you. I think they'd eat you. But my golden retriever is a super oxytocin hound. And so they actually did a study. This was just published last year about dogs and oxytocin releasing. It's totally true. My little boy, just anecdotally, this is not good research, but anecdotally, my little boy, he had night terrors when he was like 4 to 6. I don't know if you guys know what night terrors are. They're so terrifying. It's like a nightmare, but they become ambulatory, they're mobile, and they don't react to stimuli. They're just like screaming, and it's just so terrifying. So we couldn't figure out what to do. We tried everything. You go to sleep a little earlier, and you take a bath beforehand, or I cuddle you, or whatever the hell we're doing. Do you know what worked with that kid?
Golden retriever.
Golden retriever in the bed every damn time. Put the golden retriever in the bed. He would take his hands and he would like put him into her fur, and then it's like, oh my God, you little oxytocin mobile. Unrelated, also shouldn't tell you this, but I'm just doing anecdotes now. Yesterday we were watching a show and it was talking about soulmates, and he goes, Mom, pretty sure my soulmate is a golden retriever. I'm like, it's really safe, dude. Just stick with it. Okay, so yes, they have done some studies, and they're like, oxytocin is like this really popular chemical right now, and everybody's trying to figure out how to manipulate themselves to get oxytocin or manipulate another person to release oxytocin. You can squirt it up somebody's nose, but good luck having them not notice that you did so. Okay, so thyroid gland. You ready? Where's your thyroid gland? Yeah, right here. Okay, so the thyroid gland, just below your larynx, kind of looks like a butterfly on either side. So the thyroid gland secretes thyroid hormones. And when we say thyroid hormones, we specifically mean T3 and T4. So this is the first time that we are going to be able to complete a feedback loop because we have all of the parts of the story. You ready? Okay, so let's do it before I show it to you. Okay, so if we're telling the thyroid story, what organ do we start with? Long before we get to the thyroid? Hypothalamus. All right, you guys are good. So hypothalamus, and the hypothalamus secretes what relevant hormone to the thyroid story? TRH, exactly. And TRH goes where? Anterior pituitary. And the anterior pituitary secretes what relevant hormone? Yeah, thyrotropin or TSH. And TSH goes where, guys? Thyroid. And in response, the thyroid secretes T3 and T4. Your textbook goes into a lot of detail about the difference between T3 and T4. For me, you can lump them together. This one's more active than this one, but T3 and T4. Do you remember the long names of those? Triiodothyronine and tetraiodothyronine. You have to know the long names because there's so much information in the long names. 3 iodines from the thyroid, and it's an amine. Okay. Do you remember what kind of amines these are? Lipid soluble or water soluble? Okay. So now we are going to get the feedback mechanism that shows us how a healthy person's thyroid would know when you had enough, stop making it. When you don't have enough, start making it again. Thyroid hormones, T3 and T4, are primarily responsible for supporting the metabolism of almost all of your tissues, right? So they make sure that your process of cellular respiration, your anabolic and catabolic processes work well. So these are metabolic support hormones, okay? And so what we would want is if your T3 and T4 levels in your bloodstream were supposed to be here, you would want them to do this, right? To just go up and down in that relatively normal range. So how do you do that? You do that because T3 and T4, when you make them, they will go through the bloodstream and they will feed back to the hypothalamus to say, I have enough right now, and they also feed back to the anterior pituitary to say I have enough right now, okay? Now, the only reason they can feed back to the hypothalamus is because they're lipid soluble. The hypothalamus has to deal with the blood-brain barrier, but lipids don't care about that, do they? So what would happen is as soon as T3 and T4 start to get elevated, they would decrease the production of TRH and TSH. Yeah? And then as soon as this started to go low enough, you would no longer inhibit the production of TRH and TSH. Does that make sense? So what that would look like over time is in a healthy person, your T3 and T4 would go up, and when it started going up enough, it would drop back down, right? This is a normal negative feedback inhibition loop. Does that make sense to you? Okay, so that's the first one of the feedback loops that you're going to learn. Okay, and this is why I had you guys try to get you guys to start working on the names of the hormones over the break, because this is the physiology. But you can't know the physiology unless you know the names of the hormones, right? So this is the feedback loop, okay? So we're going to break it, and then I'll show you a couple of different disorders that happen with it, okay? So both of these hormones increase the metabolic rate. Keep in mind also, they're super duper important during fetal development for proper brain development. The building of a fetal brain is really, really energetically expensive. It needs a lot of it has a lot of metabolic demands, okay? So keep that in mind. So you always need them, but certain times, it's even more important. Okay, so they're lipid-soluble amines. The other thing that I need to tell you is that growth hormone, and we talked about this briefly last time, does it make sense to you that you will not commit to cell division and protein synthesis with growth hormone if you don't have the metabolism to support it? Does that make sense? Okay, so if you have a thyroid hormone disorder that's untreated, you will have a growth disorder, right? So these are needed in order for you to have the adequate, proper secretion of growth hormone, okay? All right, so let's talk about a couple of different clinical connections. You ready? Okay, so let's talk about the adult ones first, and we'll go back and pick up the kid one. Okay, so what do you guys think? If I had hypothyroidism and as an adult, can you think of any symptoms that you might expect? Hypothyroidism? Hypo. You'd be tired all the time, right? You tend to have weight gain, your heart rate is slow, you're pretty intolerant to cold, you can't heat up yourself, you're really, really exhausted, you have fertility issues, all of these things that need metabolism, you've got weight gain, all of these things are associated with it. In addition, quite often associated with hypothyroidism, you will also have a goiter. Goiter is when your thyroid says, hey, I'm not making enough, and it starts to increase mitosis to make more thyroid so that you can try to keep up. So this can be a response to hypothyroidism. This is a severe goiter, like outrageous severe goiter. So most of the time, hypothyroidism is an autoimmune disorder in which your immune system gets exposed to I don't know what pathogen, and it makes antibodies. And for some reason, the antibodies just start to destroy your thyroid, okay? When it starts to destroy your thyroid, you can't make enough T3 and T4, regardless of the fact that, let's think about this for a second. If you have autoimmune hypothyroidism and your thyroid is getting destroyed, we know that the levels of these would be low. What do you tell me about the levels of these two? They'd be high, right? You're continuing, right? You're continuing to try to stimulate thyroid secretion, but it's not working. And what that tells you diagnostically is that the problem is here. Yeah? Okay, there's another form of hypothyroidism that's just related to an inadequate amount of iodine. That one's really easy to treat. Just add iodine back, right? And so this is more common in areas of really high elevation, which is probably what happened to her. Iodine is water soluble, so if you've got a really high elevation and the water is constantly being carried down, then a lot of times there's really low iodine concentration in the water bodies, really high elevation. So even in the United States, though, you can live, Denver, Mile High City, right? And you're not going to have this. Why? Why do we not get it?
Because we supplement iodine.
Yeah, because we supplement iodine, right? Our salt is iodized. Yeah. If you don't want to supplement iodine, you can eat seafood. There's plenty of iodine in seafood as well. So that's hypothyroidism, and hypothyroidism is pretty darn common. You probably know somebody who has hypothyroid disorder. All autoimmune diseases are more common in women than in men. And hypothyroidism usually manifests in a woman's late 20s to mid 40s. And it's treatable because after it's diagnosed, you can add the T3 and T4 back. They call it synthroid usually, synthetic thyroid. And it's lipid soluble, so it's orally supplemented, right? But getting the level right is a little difficult because with this is like a real-time feedback and it's constantly adjusting itself in your body. But if you go in and you get treated, they're going to assess your thyroid levels and they're going to say, okay, I think you need this much synthroid. And then they're not going to look at it again for at least 2 weeks and sometimes 2-3 months, right? So if the level is wrong, you can flip from hypothyroid into hyperthyroid. And sometimes you can do that 2 or 3 times before they get the levels right. What was your question, Shelby?
I was going to say, is hyper and hypo both autoimmune?
Yeah, I'm going to teach you the hyper one now, too. Okay, go ahead.
If they're not metabolizing correctly, are they going to develop some sort of diabetes?
Not usually with this one, because it doesn't have anything particularly to do with sugar. It has to do with how you're just going to pee out more of the sugar. It doesn't usually cause type 2 diabetes. Okay, so let's talk about the other one. And this one's a little hard to understand, so make sure that you're paying attention with this one. Okay. There is also hyperthyroidism. Oh, by the way, one last little thing before we leave hypo. Hypothyroidism is often, where the hell did it go? Hypothyroidism has a whole suite of symptoms associated with it. There's even more than this. If you hit X number of the symptoms, then they will diagnose you with Hashimoto's disease. But you can have hypothyroid but not be diagnosed with Hashimoto's. Hashimoto's means that you met some critical number of symptoms. So don't be surprised that somebody can have hypothyroid but not Hashimoto's, and they can have Hashimoto's and they have hypothyroid, right? It's just like meeting certain numbers. And a lot of times you don't have very many of the symptoms in the early stages, and then in the later stages you do. Okay, go ahead.
I have a friend, and she was diagnosed with Hashimoto's,
Uh-huh.
and then they later diagnosed her with Cushing's disease.
Ooh, Cushing's disease we will talk about when we get to cortisol. That makes me wonder if she's got an anterior pituitary problem and not a thyroid problem, because they're both regulated by the anterior pituitary. So, and Cushing's is a much bigger deal than Hashimoto's. Okay, so let's talk about hyperthyroidism. So if you are producing too much of the T3 and T4, what do you think the symptoms are going to be? Well, kind of the opposite. You tend to lose a lot of weight really quickly, but it's not the good kind of weight loss. You lose a ton of weight. You're really, really irritable. You're super hot and you can't cool down. You can't sleep. Your metabolism never slows down enough to sleep. Your heart rate's really high and thready. And sometimes you have a goiter with that too. Sometimes it's like the goiter that's causing the hyperthyroidism. If it's like a benign tumor, it can cause hyperthyroidism. So a lot of weight loss, you poop all the time. So this is hyperthyroidism. And one of the other symptoms of hyperthyroidism is exophthalmos. So for some weird reason, when you have hyperthyroidism, you don't deposit fat almost anywhere except in the orbital fat pads behind your eyes. And so it pushes your eyeballs out, and this is called exophthalmos. So with exophthalmos, this is pre and post treatment for her hypothyroidism. So with exophthalmos, if you have a certain number of the symptoms, you are diagnosed with Graves' disease. Certain number of the symptoms. So you're going to have exophthalmos, and your heart's going to be kind of crazy. You're going to sweat like crazy. You might have tremors. Anxiety is a really common association of this. So this is exophthalmos. Oh, and she has loose stools there too. I just noticed that for the first time. Okay, so if you get a certain number of the symptoms, you have Graves' disease. Now, Graves' disease is harder to treat than Hashimoto's, because it's hard once you have too much to figure out how to get yourself to regulated on the amount. And again, if it's a benign, you're usually not going to do surgical intervention because you're going to create another problem. So sometimes they just have to treat the symptoms of Graves' disease. So let's talk about, this is weird, the way that this one is occurs. So most forms of Graves' disease or hypersecretion of T3 and T4, there's two things that can really cause it. You can have a tumor that could cause it, right? Benign or malignant that could cause it. But even more commonly, there is another way to do it, which is it's autoimmune. And I know it sounds weird. Usually, if you think about autoimmune diseases, you would imagine that they would cause a hyposecretion, but this one's causing a hypersecretion, and it's because of this. So you get exposed to whatever pathogen, and your immune system makes antibodies, yeah? And so you've got these antibodies. But the antibodies are also TSH agonists. What does that mean?
Act as TSH.
Yeah, they fit into the receptor on the thyroid for TSH, and they keep stimulating the thyroid and stimulating the thyroid. So let's talk about diagnostics. You guys, again, be the diagnostician here, okay? So the TSH agonists, so if you had this sort of autoimmune hyperthyroidism, what can you tell me about your levels of T3 and T4? They're going to be really high. What can you tell me about your levels of TRH? Low. And your levels of real TSH? Low. Do you see that that's diagnostic, right? You've got super high levels of this, really low levels of these two. So you can see where the problem is occurring. It's occurring right there. And you're losing your feedback loop. Does that make sense? Okay, so that's the autoimmune hyperthyroidism. Okay, so the question I ask you right here is, can you do the feedback loop? Okay, so which hypophysiotropic hormones, which pituitary hormones ultimately control T3 and T4 secretion? And that's that story right there. Okay, now, note to self. This is the way my brain works. It doesn't matter. Your brain can work totally differently, but it's useful for you because I write your tests, right? Okay, it's useful for you to know that that's the way my brain works. These feedback loops are the way my brain works. Okay, so the thyroid, however, secretes one other hormone that is not related to this story. And I teach this hormone in anatomy, so a bunch of you guys should already know it. Okay, the thyroid secretes a different hormone. Its chemistry is different. It has nothing to do with this story and is called calcitonin. Do you guys remember calcitonin? Anyone? Okay, calcitonin. By the way, when people say thyroid hormones, they're talking about these. If they're talking about calcitonin, they're always going to call it by name. Okay, so this is what calcitonin does. I always remember calcitonin because it tones down blood calcium. Remember the story that I teach in anatomy when we're talking about bone and we're talking about the level of calcium that you need? Okay, so this is your blood calcium. Please note that calcium is used not just for bone, it's also used for nervous system transmission, skeletal muscles, and cardiac muscles. It's also used for blood clotting. So way more than that. We really need to keep our calcium in homeostatically normal levels. So what your calcium does is this, okay? But it's controlled by hormones. And one of the hormones, after you just ate broccoli with cheese and had a milkshake, you're going to have a whole bunch of calcium in your system, and you are going to tone it down by releasing calcitonin. What calcitonin is going to do is to primarily target your bone. And it's going to tell your bone to store it. Yeah? Okay? Specifically, for those of you who care and remember, what it does is it slows down osteoclast activity and leaves osteoblast activity going, right? And so you'll get a net gain of bone mass, but your blood calcium levels will drop. Is that okay? Okay, so this is what calcitonin does, and it's not related to that story at all. So let's draw a feedback loop just for calcitonin, because it's really simple. It's a short feedback loop. Ready? Okay. Since calcitonin tones down blood calcium, what do you think the trigger is for calcitonin release? High blood calcium, yes. So right after I eat a whole bunch of calcium, high specifically in the blood plasma. Okay. And the organ that is going to be sensitive to high blood plasma calcium is what? No. Thyroid. Directly to the thyroid. And the thyroid, when it detects high blood calcium, is going to do what? Yeah, it's going to release calcitonin. Calcitonin is going to go where? What's the major target? There's more than one, but major target is the bone. Got it?
Is that mostly long bones?
All of the bones. Osteoclasts wherever they are. you know, because they're all over the place, okay? So it's going to go to the bone, and the bone is going to store calcium, right? Yeah? And then what's that going to do to your calcium level?
Lower your blood.
It's going to lower it.
And then it's gonna go to the thyroid.
Yep. And this is going to feed back as new input to the thyroid. Got it? Okay. So this is your feedback loop. Okay, so now let me ask you a logic question, not a memorization question. Okay? So you're very, very commonly going to encounter that hormones have more targets than the ones you memorize. Yes? Because they can go anywhere they damn well please. Okay? So it's systemic. But I don't expect you to memorize all of the targets, and you don't need to if you just use your logic to figure this out. So if I told you that calcitonin also targets the kidney and the small intestine, what could we figure out that it could do at the kidney that would be consistent with its goal? Heat out more calcium. Yes. See, you didn't have to memorize that. What could we have it do at the small intestine that would be consistent with its goal? Yeah, don't absorb as much calcium. You got it? Okay, go ahead.
Would it target the sarcoplasmic reticulum?
It doesn't, that I know. We've never found it there. Go ahead.
So if somebody had to have their thyroid removed, would they be at a higher risk for
Yes.
osteoporosis?
Absolutely. Mm-hmm. Yeah, they're going to have calcium storage problems. They usually have to supplement calcium after they do that. Okay, is that all right? So do you understand what I just did there? Okay, so what I can and I reserve the right to do on a test question is if I know the target that you memorized, I expect you to memorize that one, but the question could say, which of these is consistent with the major function of calcitonin? And then I give you increased calcium absorption, decreased calcium absorption at the small intestine, increased calcium secretion, decreased calcium secretion at the kidneys, right? Because that makes you just think through it, right? Because you know the major function. Is that okay? Right? Because it's logical. It's the same thing we talked about with the cardiovascular system. If you have two targets, you're never going to contradict what you do at one with the other target. Okay? And then the last thing that we will do today is just the parathyroid glands, because they're just the other part of this story. Okay? So do you know where your parathyroid glands are? Oh, I forgot to tell you one disorder. I'll pick it up next time. I want to do parathyroid glands. I forgot to do cretinism. I'll pick it up next time. So the parathyroid glands are on the back of the thyroid. Where the hell are you? There it is. They're on the back of the thyroid. There's like two little pairs. They look like little nipples on the back. They used to think they were just part of the thyroid, and then they'd cut them off on accident whenever they did thyroid surgery. And then you create another problem. So the parathyroid glands are the other part of this story. The parathyroid glands are going to be responsible for increasing blood calcium. Yes? Targets bone and kidney to increase circulating blood calcium. Also does phosphate, but we won't worry about that for a minute. So this hormone's action directly opposes the action of what hormone? Calcitonin from the what gland? Thyroid gland, good. PTH, therefore, would be released in response to what level of calcium in the blood? Low. Okay, so you guys help me build the other one, okay? The parallel one for parathyroid hormone. Ready? Okay, how do I start it? Low calcium in the blood plasma. Got it? And where is that going to be detected? Yeah, this one's parathyroid. Okay, and the parathyroid is actually going to target primarily, it's going to release PTH, the only hormone that comes from there, which is parathyroid hormone. It's peptide 2. And PTH is going to target where? Bone primarily, also kidneys. Bone's the primary one. And it's going to target the same cells, guys. Targets osteoclasts too, but this time what's it going to do? Increase activity of osteoclasts. That make sense? Increase activity of osteoclasts. And then it's going to, release calcium, right? And that increases calcium. And then what's the feedback mechanism? Yeah, goes back as new input to the parathyroid. So in this picture, every time you eat a whole bunch of calcium, you release calcitonin. Every time you've been fasting or sleeping, you release PTH. That makes sense? To make sure that your calcium level stays relatively normal all the time.
This is more
Okay.
curiosity question. What's the normal level of calcium?
I don't know. It's in the back of your textbook. Like it's got all of the normal blood levels in the back. Yeah, I don't remember numbers very well, so if I made it, if I told you, I'd just be making that. So, so what you're going to end up with is you're going to end up with some feedback loops. You're not going to end up with 34, because you see that that one actually has 3 different hormones in it, 4 different hormones in it, right? But you are going to end up understanding the feedback loops for most things. Although some of them are hard to draw, like the oxytocin feedback loop. How do you draw that? So you say skin-to-skin contact, or orgasm, or childbirth, or breastfeeding causes oxytocin, right? And then when do you stop? When you stop doing that, right? So it's just sensory. So that one's a little hard to draw, but it's not hard to conceptualize, right? Okay, I will see you guys on Monday, and you have a quiz over as far as we got, although I won't ask you about cretinism because I didn't talk about that one. Remind me to do that on Monday. What? In class, yeah, in class. Because I want to talk through the answers and make sure you guys are actually getting them. And it'll be on Top Hat in class on Monday.
Is it just endocrine or
Just endocrine, yeah.